Abnormal smear and cervical cancer screening. Worldwide, cervical cancer is the second most common cancer in women, with 500,000 new cases diagnosed each year. In Singapore, it is the 10th most common cancer in females. Between 2013 to 2017, there were 1,077 cases of cervical cancer diagnosed, with age standardized mortality rate of 2.1. Screening for cervical cancer is a recognized method of cervical cancer prevention. Cervical cancer fulfills the World Health Organization's criteria for screening, hence making it a suitable cancer for mass screening. The World Health Organization's criteria for screening include 1. Important health problem, 2. Accepted treatment for recognized disease, 3. Facilities for diagnosis and treatment, 4. Suitable latent and symptomatic stage, 5. Suitable test or examination, 6. Test acceptable to population, 7. Natural history of condition understood, 8. Agreed on policy on whom to treat, 9. Cost of finding economically balanced with overall health, 10. Case finding should be continuous process. The human papillomavirus is a small DNA virus that has a double-stranded, tightly coiled circular genome of about 8,000 Daltons. The human papillomavirus is only specific to humans, and currently more than 100 types of HPV virus are identified. Human papillomavirus infection is very common in sexually active people. It is reported that 9 out of 10 sexually active people will have a human papillomavirus infection at some point in their life. This is the natural history of human papillomavirus. Following the initial HPV infection, majority of infections will be cleared. Some persist and may progress to CIN1. This takes about 1 year. Following CIN1, the infection may get cleared or may persist and progress to CIN2 or 3. This takes about 1 to 3 years. The progression to cervical cancer from the time of initial HPV infection takes decades. Thus, this gives us ample time for screening, early diagnosis of pre-invasive lesions, and cervical cancer prevention. Human papillomavirus can thus further be divided into 2 subtypes. 1. High-risk types or oncogenic causes cervical cancer. 2. Low-risk types or non-oncogenic, non-cancer causing. The most common manifestation of human papillomavirus infection is genital warts. Human papillomavirus 6 and 11 causes 90% of genital warts. Approximately 14 types of human papillomavirus are related to cervical cancer. Out of these 14 types, human papillomavirus 16 and 18 causes 70% of cervical cancer. Anatomy of the cervix. In order to fully understand the mechanism of human papillomavirus infection and management of pre-invasive disease and cervical cancer, a sound understanding of the anatomy of the cervix is crucial. The cervix can be divided into the ectocervix and the endocervix. The ectocervix is the readily visible portion of the cervix situated at the top of the vagina. It is lined by stratified squamous epithelium consisting of multiple layers of cells. The endocervix is not readily visible and makes up the endocervical canal portion of the cervix. It is lined by a thin single-layer columnar epithelium. The junction where the stratified squamous epithelium and single-layer columnar epithelium meets is called the squamo-columnar junction. The position of the squamo-columnar junction in relation to the external os varies depending on various factors such as age, menstrual status, pregnancy, and oral contraceptive use. Under the influence of estrogen following menarche and pregnancy, eversion of the columnar epithelium onto the ectocervix happens. On direct visualization, the cervix can appear to be raw-looking and is commonly incorrectly known as cervical erosion. This condition is a normal physiological change of the cervix called cervical ectropion. The region where squamous metaplasia occurs is called the transformation zone. The transformation zone is an area between the old and new squamocolumnar junction. This is an important area in terms of cervical cancer prevention because almost all pre-invasive disease and cervical cancer occurs in the transformation zone. The following conditions increase the risk of getting human papillomavirus infection: onset of sexual intercourse at early age and multiple sexual partners of either partner will increase the exposure to human papillomavirus infection. Cigarette smoking, human immunodeficiency virus infection, history of sexual transmitted infection, and immunosuppression will result in decreased immunity and defense against human papillomavirus infection. It is important to note that it is not the presence of human papillomavirus infection, but the persistence of it which leads to cervical cancer. Pathogenesis. The human papillomavirus itself on the transformation zone is not sufficient to cause pre-cancer cell or cervical cancer. Other cofactors will be needed to encourage human papillomavirus to grow and effect changes. Cervical cancer prevention comprises of 3 aspects. 1. Primary prevention, preventing the initial infection by human papillomavirus. This can be done through vaccination, sexual abstinence, and healthy lifestyle. 2. Secondary prevention, preventing the human papillomavirus infection that has already happened from progressing further. This will be by detection and treatment of pre-invasive state. For example, cervical cancer screening. 3. Tertiary prevention, detection and treatment of cancer. Let us examine these 3 preventive measures in depth. Primary prevention of cervical cancer. Primary cancer prevention can be achieved through prevention and control of genital human papillomavirus infection. These include healthy sexual life, minimizing exposure to HPV infection, quit smoking, minimizing the number of sexual partners, and human papillomavirus vaccination. Human papillomavirus vaccination. The human papillomavirus vaccine is a viral-like protein. It is not a virus, but reassembled viral capsid proteins without the viral genome. It is hence non-infectious, but can induce increased immunity when injected by generating high levels of human papillomavirus IgG antibodies that can provide type-specific protection. It is not 100% protective, and women must still go for their cervical cancer screening when they reach the required criteria for screening. The best protection is seen in women who have never been exposed to human papillomavirus infection, such as those who have not been sexually active before. Human papillomavirus vaccine safety profile is well established. The most common side effects reported by women receiving the vaccine include pain at the injection site, swelling, and headache. To date, the human papillomavirus vaccine has not been shown to have any serious adverse effects. These are the types and characteristics of current human papillomavirus vaccines available: bivalent vaccine or Cervarix, quadrivalent vaccine, and nonavalent vaccine. Bivalent vaccine protects against human papillomavirus 16 and 18 with a vaccine schedule of 0, 1, and 6 months. It is used for the prevention of cervical cancers and pre-cancers. Approved age for use is girls and women aged 9 to 25 years. Quadrivalent vaccine protects against human papillomavirus 6, 11, 16, and 18, with a vaccine schedule of 0, 2, and 6 months. It is used for the prevention of genital warts, cervical, vulva, vaginal and/or anal cancers and precancers, oropharyngeal and other head and neck cancers. Approved age for use is girls and women aged 9 to 26 years. Nonavalent vaccine has the widest range of protection among the 3 vaccines. It protects against human papillomavirus 6, 11, 16, 18, 31, 33, 45, 52 and 58, with a vaccine schedule of 0, 2 and 6 months. It is used to prevent the same conditions similarly as the quadrivalent vaccine. However, it has a wider approved age for use, girls and women aged 9 to 45 years. Secondary prevention of cervical cancer. Cervical cancer screening. The purpose of screening is to identify asymptomatic individuals who have a higher risk of developing cervical cancer. Screening programs have led to significant reduction in the incidence and mortality due to cervical cancer. Screening methods. There are currently 3 main types of screening methods for cervical cancer used clinically worldwide. These include cytology-based, human papillomavirus testing, and visual inspection. Cytology-based screening. A pap smear involves gentle brushing to the cervix using a device to exfoliate cervical cells to allow for microscopic inspection of specific nucleic changes in the cell to look for the presence of cervical intraepithelial neoplasia that may lead to cervical cancer if not treated. The pap smear has a low sensitivity and high specificity for detecting high-grade abnormalities. It is less specific for low-grade lesion. Conventional method. This is the original sampling method using the Ayres spatula. The disadvantage of this method is the high incidence of unsatisfactory pap smear. This may be due to operator-dependent factors such as poor slide preparation, laboratory interpretation error, or presence of other materials on the slides such as blood. The use of liquid-based cytology has been shown to reduce the number of unsatisfactory pap smear that is seen in conventional method. Liquid-based cytology. In liquid-based cytology, the sampling method is the same as conventional method. However, instead of smearing the sample onto a slide, the sample is washed into a liquid medium. The liquid medium is then sent to the laboratory, where it is processed in the laboratory to produce a monolayer of cell on the slide, hence reducing the number of unsatisfactory slides. Another advantage of the liquid-based cytology is that the sample medium can be kept and used for human papillomavirus DNA testing. Human papillomavirus testing. This is currently the primary method of cervical cancer screening in Singapore, in view of its higher sensitivity compared to a cytology-based screening like pap smear. Besides primary human papillomavirus screening, there are 2 other clinical indications for human papillomavirus testing: ASCUS triage and test of cure. The most common abnormal pap smear result obtained is ASCUS. Majority of ASCUS are due to low-risk human papillomavirus infection, which does not lead to cervical cancer. In ASCUS triage, women who had an ASCUS pap smear are offered a human papillomavirus test. Those who test positive for high-risk human papillomavirus are at higher risk of cervical cancer and are referred for further assessment. In test of cure, women who have had treatment for proven pre-invasive cervical disease will be offered a human papillomavirus test at 6 months to 12 months intervals to prove that the disease has been eradicated. Women who have a negative human papillomavirus test have been shown to have a lower risk of recurring high-grade cervical intraepithelial neoplasia or cervical cancer, and it is safe for them to resume routine cervical cancer screening every 3 to 5 years. Visual inspection. Screening by visual inspection involves applying 3 to 5% acetic acid or Lugol's iodine on the cervix with direct observation of specific changes. These changes are seen immediately and allow treatment to be done at the same time. This method is used widely in countries with low resource setting. Cervical screening in Singapore. Sexually active women between the ages of 25 to 29 years old are invited for a pap smear test every 3 years, while women between 30 to 69 years old are invited for a human papilloma virus test every 5 years. Pap smear reporting. Two of the most common pap smear reporting systems are the 1973 WHO system, borderline, mild, moderate, and severe dyskaryosis, invasive cancer and adenocarcinoma, and the 2014 Bethesda system of cervical cytology reporting. This is used at present and is as follows. Principles of colposcopy. Colposcopy is a procedure where the cervix is visualized using a colposcope to identify the presence of pre-invasive cervical disease. It is done with a low-power microscopy with a bright illumination, aided by 3 to 5% acetic acid and Lugol's iodine. It is important to appreciate that human papilloma virus test and pap smear are only screening tests and are performed in asymptomatic women. Colposcopy examination plays an important role in the event of abnormal screening to detect any cellular abnormalities. Colposcopy is important in the management of abnormal pap smear as it helps to locate the lesion on the cervix and indicates severity of intraepithelial neoplasia. Its most important function is to exclude invasive cervical cancer. Allow selection of sites of the lesion to biopsy to confirm suspicion. And it also facilitates local ablative and excisional treatment. This is the summary of the common indications for referral to colposcopy clinic. ASCUS, human papillomavirus positive cases or repeat pap smear showing ASCUS in 6 months. ASCH, LSIL, HSIL and all glandular abnormalities will be referred for colposcopy. Other referrals to colposcopy when cervix is suspicious looking. Suspicious symptoms that may indicate presence of cervical cancer, that is, postcoital bleeding. It is important to note, pre-invasive disease do not cause unscheduled bleeding. Atypical colposcopic findings include punctations, mosaicism, leukoplakia, acetowhite areas, abnormal blood vessels. Ablative techniques include cold coagulation, laser ablation or vaporization, cryotherapy. Excisional techniques include loop electrosurgical excision procedure, LEEP, LEEP, or large loop excision of transformation zone, LLETZ, cone biopsy through laser, needle or cold knife, trachelectomy and hysterectomy. Treatment of pre-invasive cervical disease. The aim of treatment for cervical pre-invasive disease is to locally remove the abnormal epithelial lining of the cervix using ablation or excisional technique. Tertiary prevention of cervical cancer is discussed in Carcinoma Cervix video. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.